Hello, happy Teach Me Tuesday. I'm Lisa Houston, a clinical nurse educator, and I am here today to talk about intraventricular hemorrhage or IVH. So, IVH is a very scary diagnosis, right? You hear IVH grade 1, 2, 3, or 4, and you think to yourself, like, oh my goodness, this baby is going to have a long course. Or you are a NICU nurse in training and you hear about a baby having IVH, or you hear about IVH in a class and you think, like, oh my gosh, like, what do we do when that happens? How do we prevent this? And IVH is scary because there aren't that many things that we can do that are like, yes, if you do this, your chances of IVH decrease by 75%. We don't have these great statistics. And really, when you think about IVH, we do know that that is most likely to occur in babies born less than 32 weeks. And when we think of intraventricular hemorrhage, we do think, adults can have this. They can have bleeding in their brain. We think about that sometimes, but that's usually from trauma, from a car accident or a fall or something happening. In our babies, it's not from a trauma. It's from this fragile, very thin blood vessel having too much pressure put on it, whether that's in utero or after delivery, typically in the first 72 hours of life, that causes the vessel to rupture. And that is what's causing the hemorrhage. So these are more likely to be happening in babies with very low birth weight. And if you think about that, so I want you to think to yourself, we talk about it being in our smallest babies. Sometimes our 22, 23, 24 weekers, that's kind of probably where your brains are going. But it can happen in those 27, 28, 29 weekers who are very low birth weight, extremely low birth weight, IUGR, those tiniest babies. And what we have to think about is what was going on to them in utero. How stressed were they in utero? What was their in utero environment like? So a baby will get a cranial ultrasound at a designated time period, whether that's at day 4 in your unit, day 7. It's read by a radiologist and then it's graded. Closer to term, closer to discharge, the baby may get an MRI depending on what your unit does. But these are tests that tell us what we're seeing. They don't say, okay, there's this much bleeding in this much part of the ventricle, so this baby is going to have this version of CP. And that, to me, is why this diagnosis remains one of the most difficult to kind of really grasp and want to have to explain back to parents or to answer their questions. So we're going to do a basic overview today. Let's start with talking about some of those contributing factors. So the germinal matrix is the most common place for this to happen, right? It's this highly vascularized area. The vessels in here are doing lots of things, lots of growing, lots of cell division, becoming new centers for sending out messages down into the body. And this is where the most susceptible area to damage and bleeding occurs. Our premature babies, as you know, have a difficulty measuring and maintaining their blood pressure. And those fluctuations in blood pressure can contribute to this. And we often think, like, oh my gosh, if a baby's hypotensive, we've got to get their blood pressure up quickly. But really, we want to avoid any of those drastic and rapid changes in their blood pressure. So actually going from a blood pressure, if we're talking about, let's say, a 24-weeker, and we want that map to be about their gestational age, right? That's what we always talk about in the NICU. So around 24, 25. And so we might take that blood pressure, maybe it's at 22, get it up to 25, 26 over an hour or two. We want to have this, steady increase in our blood pressure. We don't want that blood pressure to be going from 22 to 32 and 25 and 34. And those changes are actually way more dangerous than kind of hitting and staying at 22 and gradually working our way up to 26. And then, of course, we have to talk about what's happening to the baby in utero. Preeclampsia, especially when you think about that high blood pressure in a mom and how that contributes to what the placenta, the cord, and the baby are doing together. Again, we come back to the placenta. I think if you've been following along with some of these videos or my Instagram page, you probably have seen a lot about the placenta. But really, it plays an important part here too, because we don't want major swings of the blood in utero getting to the baby either. So how can we help control some of those things? So when we talk about the physiology and etiology of what's going on here, so with the physiology, we really think about the germinal matrix, how limited the space is in there, how this can spread out into the ventricles as more and more bleeding occurs, as you get more of a fluid push. And really the most common cause, this etiology of IVH, is a fluctuation in cerebral blood flow. I think what we always think about, what I always thought about, I'll just think about myself right now, right? I'm coming up on my 20 years of being a NICU nurse, and it really didn't dawn on me for a couple years that a lot of this could be happening in utero. That maybe they aren't born with a grade 4 IVH, but maybe some of those vessels had damage to them from asphyxia, from shock, from volume changes in utero. Yes, all those things can then happen after they are born, but it can happen in utero. And then in that first hour of life, which we already talked about the golden hour previously, go back and check that video out if you haven't, but really in that first hour of life, if we're talking about intubations, right? Intubations, when we're moving their head, when we're trying to do kind of this painful procedure, that's going to cause a change. So that's things that can happen to the baby even before they get to us, the bedside nurse. So then we get the baby and we kind of do those things we know we're supposed to do during the golden hour and those hours after. And maybe the blood vessels have already ruptured, and that can be kind of a hard pill to swallow. But that is why for those first 72 to 96 hours, depending on what your unit practices, you're going to have this midline period where we really are doing extra neuroprotective care to try to prevent some of these things that can happen from the asphyxia, from the shock, from the volume expansion. Pneumothorax. It's a huge contributor to IVH, and that's because there's this rush of blood into the brain, and it's a major change in the baby's hemodynamics throughout their whole body. That lung collapses, where's all that blood that's in there got to go, right? So just things to think about. So when you as a bedside nurse are thinking about what could I be watching for, these are some of those things. Our thorough assessment is always going to be so important. Feeling that fontanelle, knowing what your fontanelle felt like at the beginning of your shift. If you're worried about the baby, that's a great thing to do in bedside report, to really like measure, like, hey, what is this feeling like? What are you feeling? What am I feeling? Noticing those changes in hematocrit. Have they had a drastic change? Now, changes in hematocrit in the first 4 days of life are also hard for NICU babies because we take a lot of blood from them. But we shouldn't be seeing, a 50 down to a 25 in 24 hours just from blood draws. So we're talking about those drastic changes or a drop that was unusual or not compared to a lab draw that we've done. Obviously, if we're seeing seizures, we might be already at late signs and symptoms of what's happening here. Changes in our apnea and bradycardia, those things, maybe the baby has a pneumothorax and you're like, okay, now we probably need to put IVH on our worry list because of this pneumothorax that we've had. So we've had these signs and symptoms. Maybe we've had a major change in our blood pressure and we've had to give either boluses, right? So in NRP, we talk about how we give boluses quickly during our resuscitation, but in our units, they are even more and more in the current research talking about giving boluses over 1 to 2 hours, again, so that we can have that slow, gradual change in our blood pressure and not have a major change in our baby's blood volume. So I always was giving them over 30 minutes at the beginning of my career. So we just are constantly evolving and changing and seeing, hey, what is the best practice here? So we get that cranial ultrasound and it comes back and they say the baby has a grade 2 IVH. And you're like, okay, grade 2. Grade 2 is not grade 4. Grade 4 is the worst, so it's not grade 4. This is just a simple rundown of what they are. I have a few pictures that I've gotten from the internet, so I'm going to show you with the sources there. But I just wanted to kind of quickly look at this, right? Grade 1 is that mild. Some of them babies with mild grade 1 IVH, you may not see any soliloquy later in life. You may not see any long-term differences. They may have some learning differences. Some of those things are hard to pinpoint on. Was it because of the grade 1 IVH? Or was it because of being a premature baby? Was it because of being in the NICU? Like, any of those things can kind of contribute to that. But grade 2 is we are extending towards the ventricles, but the ventricles are not getting bigger. We can have some clinical implications, but again, grade 2 can be usually manageable. Also, very interesting thing about grading. Unilateral grade 4 is often better for a baby than bilateral grade 2s. So it's when one or both sides, of course, is really bad. Anywhere where you have that grade 4 is the most severe. So grade 3 is it indicates bleeding into the ventricles, and now you have ventricular dilation, and they have long-term neurodevelopmental issues. And then grade 4 is the most severe, bleeding around the brain tissue. We're talking about those babies that end up with cerebral palsy, etc. So let's take that grade 1, 2, 3, and 4 and look at these 2 slides of pictures that we have talking about this. So this came from a sonographer's Facebook page, which I just found so fascinating that they were kind of doing this drawing and comparing it. So remember, in the developing premature baby's brain, if you're looking at a cranial ultrasound, you want to see black, right? This black area is good. That's nothing terrible happening here. It's when you start seeing the white within the areas that you are seeing this area of bleeding. And grade 4 is often going to contribute and can manifest into periventricular leukomalacia, or PVLs. And that's just when that area of the brain has become so damaged that it's beyond kind of repair. But if you look over here at your normal brain, right, we've got our black areas. That's showing you what this is here. Here's your germinal matrix, these little areas forming. You've got a little bit of bleeding in there. Grade 2, the ventricles are not expanding. Now we're getting where our ventricles are dilated in grade 3, and then grade 4, it has gone outside the ventricle. So one more quick picture. Again, this is from Children's Hospital of Minnesota. I think it's another kind of great view of just what am I looking at. They have a great resource on their website. So if you're looking for another source, that'd be a great one. But here you have bleeding near the ventricle, in the ventricles are enlarging, and now we have blood in the brain tissue. So again, just kind of those 4 ways of looking at it. I think that these pictures are very helpful if you're a visual person to kind of go along with the words of what does this mean. So when you think to yourself oh my gosh, this is such a big deal, what can we do to prevent it? One thing that I think is so interesting about prevention is if you are having grade 4 IVHs, you're probably doing some sort of swarming or debriefing, hey, what's going on? Was there any spot that maybe we could have done something better? And in those things, they should be done with your labor and birth team, whether that's your education team, your leadership team, a medical provider, because it's hey, were we on prenatal steroids? Where was the baby delivered? Were they delivered in the OR versus the labor room? What did we do to prevent this preterm birth? How were we controlling the maternal blood pressure? What was the monitoring labor and deliveries that we could notice, hey, we're having some issues. We don't want to have any asphyxia. Let's get this baby out. So great pairing up there. One of the other things that we are looking at during those debriefs or swarms or clinical investigations, whatever you want to call them, is the temperature, right? We talk about how important thermoregulation is, but what was the temperature at delivery? What was the temperature on admission? What was the temperature in the first few hours after admission? Because those major dips in temperatures can also contribute to our IVH. So postnatally, we as the bedside nurses are doing these golden hour care bundles, right? We talked about the golden hour in a previous slide deck. I recommend going back and kind of looking through that one. We have our neuroprotective care bundles, hey, what are we going to do for the first 72 or 96 hours? Where I currently work, we do the 96 hours of the midline positioning. Now, we also say that midline positioning still means the baby can be held skin to skin. We want to still get that baby on the mom whenever we can, because we know the benefits of kangaroo care and skin to skin. So what can we do to help get them out? With blood pressure control, again, we don't want to have those major swings up and down in our blood pressure. How can we optimize nutrition, prevent excessive blood draws? And then there are studies out there about indomethacin or ibuprofen, about various supplements we could give the babies, about Epogen, but none of them have yes, we saw more than 50% improvement with this treatment plan, so everybody should do that. There's still some pros and cons going on here, so it's important that you kind of look into that if your unit is considering some of those treatments. So what we do for treatment of IVH really is the blood pressure, seizure suppression, our ventilation support, our oxygen, our acid-base balance. Remember, weighing out ventilation versus oxygenation, which was our very first slide deck, so I'm sure it's rough from a few months ago, but I'm going to go back and watch that one. But those babies that do end up with post-hemorrhagic hydrocephalus and end up with a shunt or a reservoir, we need to be really, and our babies with grade 4 IVHs before we get there, we're probably doing daily OFCs or every other day OFCs. We're doing those thorough fontanelle assessments. Once they have a shunt or a reservoir, is really infection prevention, making sure if we're doing any taps of that, what is our cleaning, how are we cleaning it, what are we doing best for the baby, is it a sterile environment when everyone's in there doing the procedure, so how can we prevent any infection from happening for the baby. Other nursing interventions that we can do is we are just watching for those drastic changes in the intracranial pressure in their ICP. So blood pressure, fluid management, assessing the fontanelles, watching your urine output, calculating your urine output in mils per kilo per hour. So you know like how well is the baby urinating? Are they retaining a bunch of fluid? What's our total fluid goal for the day? Are we including every flush that we give with that? So are we staying within that safe range for the day of life that the baby is? And then, of course, our parent education. Do they know the plan of care? Are they looking for the signs and symptoms of concern, including changes in the baby's state? So are they lethargic? Are they irritable? Are they having some poor feeding? What can we do to support this baby, especially as they get older? And then, of course, teaching them our neuroprotective care guidelines for those first 96 hours. I think one of those things really also to keep in mind is how are we handling the babies? So that kind of goes into our recap, which is this can be a detrimental diagnosis. We hear those words and we get very nervous, but really thinking about slow movements. I can vividly remember 20 years ago doing the preemie flip where we would just pick the babies up and we would flip them over because we didn't know any better, but we know better now. We know that we should be rolling them slowly to their side, giving the baby time to recover, rolling them to the back, never lifting the legs for those diaper changes, right? Lifting up as much as we can, scooting the diaper under, whether we're using our mattress or whatever we're using for that. Having those slow changes in our blood pressure. So if our blood pressure is dropping, how can we slowly bring it up? Can we make incremental changes in our vasopressors, such as dopamine or dobutamine? Instead of being like, oh, it's 22, let's start at 10. Like, no, maybe we should still start at 5 and do some incremental changes so that we can get the baby to a safe place. So that is today's Teach Me Tuesday. Come back next week. Next week is our first time having a part 1 of something. So little teaser for you there. But yes, let me know if there's anything else you would like to hear, and have a great rest of your day. And I hope you enjoyed today's review of intraventricular hemorrhage.